Hustle out. Good afternoon, everybody. I'm Jerry Nolan from Bath in the UK. It's a pleasure to co-moderate this session with Rinaldo Bellomo from Melbourne, Australia. This session is entitled How to Use TTM After Cardiac Arrest. It's supposed to be a kind of practical session. You'll find there's a bit of practical bits and there's also a few slides, but hopefully there's a lot of discussion as well. What I propose to do is go through very briefly a quick case, and the details of the case are not that important to start with. It's more about the management of this person as far as temperature control is concerned in the ICU. And then I'm going to go through just very briefly where we are now with the current guidelines on temperature control. Then we'll have a little bit of a practical session, and then Rinaldo will finish off with the second half going through some details and some recent data on the kind of impact there has been as a result of recent trials on temperature control. So hopefully that should see us through. Just that we've only got 30 minutes, so it's a lot to get through. So this is our case. As I say, the details are not critical. It's basically a person who's had a sudden collapse at work. He's been had some bystander CPR. The emergency services have turned up after about 8 minutes, so that's a pretty reasonable time for bystander CPR. His initial monitored rhythm is ventricular fibrillation, so he gets treated. They eventually get return of spontaneous circulation after 6 shocks. So that's a pretty reasonable period of CPR, probably around 15 minutes plus. He's then taken into hospital, into the ED, and then I'll show you his ECG. Basically, he's got ST elevation in his anterior lead, so he goes to the cath lab, gets a stent in his LAD, and then comes onto the ICU with a temperature of 36.7, which I suggest to you is actually a relatively high temperature on average for patients when they arrive in the ICU, having gone through the cath lab, etc., because it's often, as I'm sure you're aware, probably down 36 or less in many cases. So that's his initial temperature. There's his ECG, so he's just got ST elevation there, and that's what he had before he went to the cath lab. So that's just setting the scene for you. So we've got our patient who's arrived, he's had a significant period of cardiac arrest, and we're going to deal with him on the ICU, and the focus is going to be around temperature control. Notice that I've used on my slide the term temperature control as opposed to TTM, and I'll go into a little bit more detail about that in a minute. It's to do with the new or preferred definitions that we're using. If you look at the recent systematic review that kind of underpinned the recent guidelines from ILCOR, from the ERC, and indeed from the AHA, this was the systematic review that compared 32 to 34, so around 33, with normothermia. So these are the randomized trials that are out there. Just to highlight the point, there are only 3 of those trials with significant numbers of patients. The rest of them are all less than 100 patients. And if you look very briefly at the forest plots for those, you can see no significant difference either in survival, so that doesn't show on the screen, survival at the top one, and then on the bottom one there, neurological outcome at 90 to 180 days. So I guess the point estimate is slightly favouring targeted temperature management or hypothermic temperature control, but basically no significant difference. And this was the point I was making about definitions. I think the problem with using the term TTM is it confuses it with the specific TTM1 and TTM2 trials. So ILCOR, after a great deal of debate, I have to say, have come up with these definitions. So the preferred term in general is temperature control, and you can either talk about having hypothermic temperature control, which I guess is equivalent to what we would call TTM in the past. You can have normothermic temperature control, which, as I'll show you in a moment, is where we are with the guidelines. You can have fever prevention temperature control, or just do nothing, no temperature control at all. So that's where we are with definitions. And then as far as the recommendations from ILCOR are concerned, I'll quickly go through those because of time. That's the most important one. So we've really kind of shifted away from using hypothermic temperature control to really it's really normothermia, preventing fever by targeting a temperature at less than or equal to 37.5 degrees. Exactly how we're going to do that is what the focus of this discussion is all about, because I think that's not completely clear yet. Second point, and this is the bit that gets really controversial, I can tell you there were many, many hours of debate about the evidence and what the guidelines and recommendations should be. But there were significant numbers of experts that still felt very strongly that there may be subpopulations of patients that might benefit from colder temperatures and hypothermic temperature control. And I'm specifically thinking of patients perhaps with a moderate degree of hypoxic ischemic brain injury. But I won't go into any more detail on that now. We've also said very clearly that if patients arrive with a temperature that's in the mild hypothermic range, they should not be actively rewarmed. We've also suggested you can either use surface or endovascular cooling. We're going to show you the surface system here, but there's no good evidence really for one or the other. I think the really important thing is that whatever we use it with some form of feedback system. But notice that although there is some evidence to support this point, that point about using feedback systems is a good practice statement. So that means that a bunch of people thought it was a good idea. The evidence is not great, but we still put it there as a good practice statement. And then we're suggesting temperature control, preventing fever for at least 72 hours. Now this, of course, was before the recent publication of the box trial that showed no difference between essentially 36 hours and 72 hours of temperature control. So whether that will change these guidelines in the future remains uncertain. And then the only other point, which is not relevant to this bit, is that we recommend against using ice-cold fluid pre-hospital for cooling patients. There's some evidence of harm for that. And then that's where we are with the ERC recommendations. Sorry, it's a busy slide, but that's the top one there, which is completely consistent with the ILCOR recommendation. And there's that second one there that just talks about leaving the window open a little bit, maybe for some populations of patients. So let's go back to our patient. We've now been in the ICU for a while, and the temperature is now up to 37.8. So what should we do at this stage? Anybody want to say what they would do in their unit? Is there anybody that would have put temperature control on this patient when they first arrived? So the temperature initially was 30, what was it, 36.5 or 36.6? Would you put temperature control on then? With the device? No? You just wait and see. Yeah, which is reasonable, which I think some people would. Would anybody put a device on straight away? Yep. And why do you do that? Yes. Great point. I'll repeat that because that's exactly what the point that I wanted to bring out. So if you kind of follow the guidelines and say, well, actually, we're going to wait until the temperature's 37.6 or 37.7 before we start to think about temperature control, there can be quite a significant delay between making the decision to do that and actually getting on top of it. And of course, you get this massive overshoot. Now, whether that's, the belief is that that's probably harmful if that temperature goes above that. But to be honest, the evidence is not strong, and I'm sure there'll be more studies in the future looking at that. But our current evidence and where we think it is that we should be desperately trying to keep that down and not let the patient go pyrexial. And I would say, although we're showing the surface cooling, I will admit in my hospital we use the intravascular system. The downside of the intravascular system is that there can be a bigger delay, I think, getting that on, because with this system, as you'll see in a second, it's pretty easy for any of the staff to put this on, whether they be nurses or whatever, and they can get that on pretty quickly. Whereas the intravascular system does rely on having somebody who's got the time and the experience and the skill to put the intravascular device in, so that there may be an advantage in terms of time for doing that. Should we do that now? Because I'm conscious of our... Yes?
I often have this confusion, like you want to prevent fever, like you want to keep it below 37.3, you just said. Yeah. Okay, but you have to set a temperature on the machine. So what temperature do you set on the machine?
Okay, so that's a very good question. So we in our hospital currently we use the intravascular system, and actually we do put it into most of the patients when they first arrive, in fact. And you can argue that that is maybe not the right thing. But what we do is set it and leave it on standby. So we won't activate it until they reach that temperature. So what you do not want to do is anticipate the temperature rising and then sort of actively, if you set the target at 37 37.7 or 37.5, you may be actively rewarming them. So you absolutely do not want to do that. At least that's what we think. Again, I have to say the evidence for that statement is not strong. But we don't want people being actively warmed up to that target. It's about stopping them going above it. Does that kind of make sense? So basically, you can put the device on if you're going to use it, put it on standby mode. Any other comments on that? Hopefully you're seeing. Christian, did you want to say something about as you're putting this on?
Are there any questions? How to use it or what we are doing there? It's quite easy, straightforward. Select the right size of pads. You need 2 people, as you see, to apply it. It could be a doctor, could be nurses. It takes 5 minutes, and we're good to go.
And you're going to, how many different size pads have you got?
They are available from neonates, also for newborns up with HIE, up to very heavy and big adults. So patients, my personal record was 260 kilos. Everything becomes slower, but it still worked. So it's a full range, pediatrics, adults, neonates. So
okay.
One for all.
I'll let you carry on. So you don't want this patient's temperature going too high in the meantime. Any other comments on, who in the room uses the surface cooling system here? Just raise your hand if you use that one. Okay, that's interesting. So that's a significant proportion. Who uses intravascular cooling? So it looks like surface cooling, they'll be pleased, surface cooling wins that vote. Those of you, let's going to pick on somebody. Why surface, intravascular cooling, I think you said, didn't you? Why do you use that? Where do you work? I'm glad you didn't say Bath, which is where I'm at. Good. Okay. So the comment was it's simply what was used in that hospital. And I think probably in many hospitals it's probably depended on individuals who have championed one system or another. I mean, that's why we use intravascular in Bath. We've used that for years and years. And I guess we haven't changed. That's good. Well done. So that's pretty fast. And I have to say, if that genuinely reflects what would happen in a real patient, that's a damn sight quicker than I can get an intravascular system in. I've got to be honest. After that, in terms of differences in the devices, it's pretty hard. I mean, I guess there's some evidence saying maybe slightly tighter control with intravascular, but you're trading off the ease with which that goes on. So I'm not, by the way, conflicted in any way. I'm not paid by these guys, and I'm not paid by the intravascular guys. I'm paid by nobody. So I think there are pros and cons of both systems, and it may just be whatever is being used in your hospital. The challenge, and I think the interest from the industry, and I'll just almost close and hand over to Rinaldo, is I think the concern is that based on the evidence out there, because we're struggling to show real benefit from hypothermic temperature control, there is a concern that in many institutions, in many hospitals, they've sort of abandoned using temperature control altogether, and Rinaldo will show some data to reflect that. And that's certainly the general belief from pretty well all experts around the world, is that's not what we want people to do. We're still very keen that we're at least preventing fever and going for that normothermic target. We accept there are many. Are any of you using still hypothermic temperatures? 33. So anybody else using 33 still? Yeah, because you'll find in some parts of the world it's very common. I think probably in the States it's quite common. I think in Germany there's probably more hospitals. And Austria, yeah. So there's a lot of people who still, despite all the things I've just shown, are keen to keep using those cooler temperatures. And are using it in all arrests, or you're picking outwards. So how do you make, hang on, I'm going to give you the mic. Tell me how you select temperatures to patients for cooling to 33.
So it is tricky. It's not 33 that we often aim for. It's kind of 34, 35. So, but duration of downtime and whether it's shockable or non-shockable. So non-shockable, protracted downtime, perhaps an older patient at greater risk of a poor neurological outcome is often what we would choose, and then we would insert an intravascular device early on in the emergency department or cath lab. An observation or a comment, anecdotal, if you ask many of the intensivists what they would want if they were in cardiac arrest and were resuscitated, many of them say they want mild hypothermia, which is quite interesting. A comment.
And where do you work, by the way? St Thomas's, okay, so that's quite a big unit. How many arrests are you getting through your ICU? more than 100 a year. Yeah, yeah. So it's interesting to see whether there's a difference between some of the larger so-called cardiac arrest centres, for want of a better word, and other hospitals. I mean, to be honest, we still really target 36, actually, and I haven't shifted from that because I'm sure all of you agree, to change what the practice in your institutions is a massive effort to train all the staff and everybody. And I kind of think, well, 36 is normothermic-ish. Well, strictly speaking, it is normothermia. Yeah, exactly. Well, we're just within the room. It's massive, isn't it? Anyway, I'm conscious of time, so let's hand it to Rinaldo to take us through some of the data in terms of what's happened since TTM trials.
Yeah, thank you very much. That's cool. So, we talked about temperature control. In my unit, we talk about stewardship, where you're actually just paying attention to what you're doing. And you've heard some of the issues that relate to this. You're all familiar with the TTM1 trial. And the reason I'm presenting the TTM1 is that I'm going to show you what happened in Australia and New Zealand after the TTM1 was published, because we don't yet have data after TTM2 to show what's happened in terms of practice. And the reason that we have some information is that we have a binational registry that provides us with the highest and the lowest temperature in the first 24 hours of ICU admission across both Australia and New Zealand for all patients as part of the Apache 2 scoring system, but also, of course, we can look at patients after a cardiac arrest. And you're familiar with the separation, the patients into two groups. And in TTM1, they were unable to show that there was a difference in neurologic outcome or mortality-related outcome at the appropriate follow-up period between aiming for 36 and staying tight there versus aiming for a lower temperature and staying tight there. And you can see there no significant difference in neurological function and no significant difference in mortality. So using the registry from Australia and New Zealand, we wanted to see what appeared to have happened after the publication of this trial. And we hypothesized that the TTM1 consequences would have led to changes in the practice of temperature control. And then we wanted to see what that kind of change in behavior would be associated with. So this is a big registry. We now have more than 2 million patients in the database, and you can identify lots of people with cardiac arrest. That's 140 hospitals, it's 16,000 patients. So that's a pretty robust data set to give you an idea of what people were doing after the events. So this is before TTM1, and this is the cohort after TTM1. And you can see there are some differences. There are some differences in age, a little bit younger, the population of patients. The kind of patients were admitted to a tertiary institution was a little bit bigger. So there are some differences in the characteristics of these patients, but broadly, there was quite a degree of comparability. What you can see there is looking at the lowest body temperature in the first 24 hours, because this is recorded in the database. And you could see that looking back, right, over many years, you could see before TTM1, the people were progressively shifting towards hypothermia. And this is 34. And people were starting up there, and this is about 100 months or so before TTM1, so it's several years before TTM1, and this is highly significant, that this slope, we were all going towards hypothermia. And then this is TTM1. So for those people who say, well, people don't take up evidence, yeah, that's pretty spectacular, right? Bang! Immediately. So two things happen. One is the temperature went up, and then over the ensuing year or so, it kept on going up. So this was keeping going down, we changed, and now we're going up. And this is what happened to mortality. Okay. So the mortality of cardiac arrest patients admitted to intensive care units in Australia and New Zealand over a period of several years was progressively declining. So we're sitting about 62%, and we're going down to about 51, 52% over that period of time. And then TTM1 came, and then things changed. And two things changed. The mortality went up, and the slope went up. So as progressively the temperature went up, progressively the mortality of patients went up. Now, it's important to mention a key fact. Mortality is not necessarily the key outcome for cardiac arrest patients. It is survival with a good neurological outcome, and we can't measure that. The registry does not have 6-month follow-up of neurological performance with these patients. So all that we have is the mortality at hospital discharge. So maybe this is a good thing, that we didn't cool them as much, we warmed them up, we made decisions more rapidly, we made an assessment of the patient more rapidly. We said, you know, these people weren't cold, we can assess them quicker, this doesn't look good, we're going to pull out. Maybe that's a better decision. But in the face of it, when you're looking at this, it's a little bit scary. Okay, so now we go, what was the management, right, that was taking place in TTM2? Right? Because you need to contextualize the data that we get. And this is about the use of devices. So whatever you think about TTM1 or whatever you think of TTM2, the standard of care in the trial centers was to use a device. And so it's very difficult to make assumptions about what the outcome would have been if the devices had not been used. Right? You say, well, I'm sure it won't matter. But there is a big difference if you practice, as I do, and have practiced with devices for 20 years. There's a big difference in temperature control if you have a device that's keeping the temperature where you actually set it versus telling people, look, I think we should keep the temperature kind of okay. You go back 2 hours later, and it's 38.2. And you say, what the hell? Didn't we agree that we were supposed to do that? Well, it doesn't really happen. So this is important. This is important. The TTM2 and the TTM1 trials were in a context of very high utilization of devices. And I kind of like these devices for another reason, and that is that when we measure, when we set up the temperature control, we can also estimate the energy transfer from the patient to the cooling device. That is, how much work the device has to do to control the temperature. And that's kind of nice because once you start seeing this kind of graph, you realize that the tendency of the patient to develop a fever looks like it takes about 5 days to settle, right? And so if you let go early on, it is likely that you'll have a rebound surge in temperature in these patients. So that's an important consideration. The device doesn't just allow you to control the temperature, it allows you to have a sense of what the tendency is in these patients. And you know, this is again a further follow-up of these patients that we showed you before, and now we looked at what are the chances after TTM1 the patients admitted to intensive care after a cardiac arrest in Australia and New Zealand would develop a fever in the first 24 hours. It's pretty spectacular. So TTM1 came, and the Australian intensive care community said, oh, great, we can do whatever we want now. Everything will be fine. It's okay. This is a pretty spectacular thing. We can argue about, you know, whether we need to have a temperature of 33, 34, 35, 36. But the advice is we probably should not have a temperature of 38.5. But we did. But it happened. And this is the problem with the translation of trials into practice. And again, that's the updated stepwise change in mortality over a prolonged period of time in a continuation of the data that I showed you. And again, this is another graph. We're giving you a little bit of a glimpse about what happened after TTM2. We don't have enough data yet, but you can see this is in the patients where after TTM1, we'd already moved up. With TTM2, it's moving up even more. So when we look at it, I expect we're going to see more fever. And also the lowest temperature shifted up. So we shifted up to TTM1, which doesn't look good. And now with TTM2, we probably shifted up some more, which looks worse again. This is data from the UK. Would you like to comment?
Ronaldo, thanks. I thought I'd just put one slide in from the study we did in the UK. So this was very much, I have to say, copying. Maybe that's a bad term. We used exactly the same methodology of the ANZIX group. So they did that for Australia and New Zealand. We obviously had the ICNARC database for pretty well the whole of certainly whole of England at least. So it's a huge data set. The reason I'm showing the slide is it's actually really complicated, this. So you can clearly show temperature changes over time, as Ronaldo's shown you on his slide. These are, and I'm sorry, this looks horribly confusing, and there's lots of stats involved, but I think I can try and talk you through the main message. So there's 4 graphs here. This is looking purely at acute hospital mortality here. And this is the raw data. And it's looking at the change around the time of the TTM1 trial, so not the 2 trial, TTM1, which was December 2013, I think, Ronaldo, wasn't it? And so you can see here, there appears to be a slight shift in mortality here, but this is unadjusted for sickness severity, for example. And we know actually in this period that these patients were indeed a bit sicker. So the obvious thing is, okay, well, let's adjust it. We've got ways we can do that. We can use the ICNARC model, which is what's commonly used now by the ICNARC Centre there. And if you do that again, you still get a slight shift suggesting an increase in mortality. The trouble is, and this is the main message I want to get across to you and why it's really complicated, both Apache and ICNARC use temperature as one of its predictors for outcome. In these patients, we're artificially changing their temperature. So you could say that in the years before, these temperatures were relatively low. So using ICNARC or Apache scores, they would have predicted a higher chance of death, you see what I mean? So it's all about statistical manipulation. So what do? We then reanalyze the data, taking temperature out of the calculation. So you take it out of the prediction model, and you can see visually, I hope, even from the back of the room, you start to completely flatten this mortality. And actually what you should do is not just take temperature out, because of course certain things like CO2, pH and things, they can be influenced by temperature. So then you end up losing half of your physiological variables because they're impacted by temperature artificially because you've changed it. So when you do that, it's completely flat. So actually, we can't show any definite change in mortality at all, and actually pretty similar things found on the ANZIX group. But it took me years working with David Harrison to try and get him to translate all statistical knowledge for me to understand that. But once I got it and we had to obviously understand it to write the paper, then I suddenly realized, and it also brings into question all these modeling and adjustments that are made for all sorts of things. For the whole time we've been artificially changing one of those variables, it's going to completely throw out these models. So what's the message? There's definitely a change in temperature, and you can see that both the stepwise change and the slope. But in mortality, I don't know. We don't know. So the jury's still out. And I think if you've got more slides there.
Thanks very much. And, that's all sorts of a really important point. And I just wanted to emphasize that with the TTM1 trial, we had significant utilization of devices, and that's a really important aspect. And so it is something that you need to consider when you're dealing with these patients. We changed the practice. We've got a higher temperature, more fever, and we can talk about the mortality modeling, but certainly more fever. That's inarguable because that doesn't require adjustment. And so even if you forget about the mortality, there was a signal that people were not protecting the patients from fever. TTM2 provided more data, and after TTM2, just looking at the preliminary data that I showed you, it looks like we're going higher up than after TTM1. So we're shifting up even higher. And so my view is that stewardship of temperature is an important thing, that if you don't apply the protocols and you don't use devices, you cannot control the temperature in a reliable fashion, and using devices ensures better stewardship of the patient's temperature. Thank you very much.
Probably a couple of minutes. Yeah. Thanks, Rinaldo. That's excellent. Yes, we've got a couple of minutes for questions. Yeah, I'll bring the microphone across.
Do you think there'll be a trial that will test no temperature management and let the body does what it's supposed to do?
I thought there was going to be.
Yeah, look, I think so. There is a trial coming on. It's called Step Care, which is 3 different arms of blood pressure, oxygen, and temperature management in a 2x2x2 design, which is funded, and it will be run by Nicholas Nielsen, who's guided TTM1, TTM2. The design is still being tweaked, but it's possible that there'll be some degree of abandonment of this level of temperature control. But I think then you'd have to ask yourself, why would you do that? You know what I mean? Like, it's difficult to say to a family or a patient proxy and to your colleagues, we've got all this experimental data, all right, in animals. We've got all this preliminary data, and we've got no evidence for us to want to argue, yeah, let's let them have a fever. That's really great. Yeah. Like, you know, if you want to sell a particular intervention, such as let the fever happen, you have to have some experimental data, some logic. You can't say, oh, we want to make sure it's just the same as the other. Do you know what I mean? You have to offer a benefit. And at the moment, it's inconceivable physiologically, experimentally, and on the basis of the information available, to believe that allowing a temperature of 39 is going to be beneficial. It's just not. You can't sell it. I couldn't sell it to a family, right? Now, and you're not going to do a trial just to show that it's okay. You have to provide a benefit. You have to promise a benefit, and I don't think you can do that.
So I think, and correct me if I'm wrong, Rinaldo, so the Step Care currently, and certainly that's what's on the protocol site, is that they will be looking at normothermic temperature control with a feedback device or without a device. So I think I've got that correct. So the answer to your question, I think, will be, if there's no difference in that domain of that trial, the next trial, I suspect, will be no fever, potentially no fever control, with all the caveats that you've just said. But the question is would the intensive care community have equipoise to do that trial? And that's been the challenge throughout. And Nicholas and his team have been very clever in the way they've graded these TTM trials. So they're moving further and further away to, you know, from a strong belief that cooling was absolutely essential. So now we're not sure. You can see how they're doing it. But whether he'll still be alive at the end of all that, I don't know.
Biological plausibility, right? You fall in love with trial technique rather than reality. That's
I'm conscious I think we're supposed to finish at past, aren't we? Was that true? We've still got 4 minutes. Okay, we've still got 4 minutes. Any other questions? Any other thoughts? Duration, we sort of touched on that. Do most of you continue temperature control for 72 hours? Anybody going to change their practice based on that box trial? So the box trial was that sort of, they managed to get 3 trials in one, didn't they? And the third one was essentially temperature control for about 36 hours versus 72. And they showed no difference, and their primary outcome, I think, was a composite of death and poor neurological function. And there was absolutely no difference between the 2 arms. So again, that would suggest we don't need to continue temperature control for 72 hours. I don't think, there's no plans to change the international guidance yet. I think we're still going to stick with that for the time being, but it's something that's going to have to be discussed at international level. Yeah.
Now that we're keeping them at 36, 37, usually we stop sedation quite early. So if they already wake up, then do you stop TTM?
So just last week, I was just telling this story. I'll be careful without getting too many patient details away, but a very young patient had a cardiac arrest, VF. They were in arrest for 40 minutes. And the next, so 24 hours, I arrived at the bedside to do the morning ward round. I said, we need to think about doing a sedation hold, because there was no reason not to at that stage. And the nurse at the bedside told me, well, actually, we've been having to turn the sedation up all night because he keeps trying to pull his tube out. So the answer is turn the sedation off, extubate the patient. And then, as far as temperature control is concerned, if they're awake, in my view, there is no point in continuing to do that. It's all about, it's about cerebral recovery. And if the patient's already made that, that might be a controversial statement because, of course, yeah. Yes, because we did that. We sort of stopped temperature control. It wasn't really an issue. He didn't develop a significant fever. But I was just saying to Rinaldo, this person made a remarkable recovery, but the short-term memory was, which is common, completely shot. So if that person had developed fever, could you argue that this person's terrible short-term memory was a result of me not continuing that temperature? I mean, I'm just putting it out there because it's a real example. It happened just a few days ago. And it's a good point to debate. I don't know the answer, but I know my practice would probably be to stop it if they're essentially awake. So, any other thoughts? Yeah.
Yes, please. When is the earliest point that you stop sedation if the patient is at all stable with no hyperthermia?
That's a good question. So for us, it is about 24 hours. If they're completely stable, we want to see what they're like. In case we can awaken them, I would stop at 24 hours. If they're unstable in any way, then I wouldn't do that. But for this person, for example, it was reasonable to do that. There are experts around the world, and Nicholas Nielsen, I'm sure, is one of them, who would argue, why do we sedate them for 24 hours? What's the evidence even for doing that? And there isn't any. So the question's a good one. This is what we do. I don't know whether that's really correct. But pragmatically, it's easy to do that. But so 24 hours is the absolute earliest. The vast majority will go longer than that. Any other final thoughts? Yes. Yes. So you mean in terms of the temperature control? Oh, I see what you're saying. So in terms of where do we measure? So we use bladder temperature. Again, I don't think there's strong evidence sort of for or against temperature site, and there's all sorts of pros and cons. I think bladder is really easy to do because it's integrated within the urinary catheter. We can get all those put in.
Yeah,
is that what you use?
Accurate representation of core temperature.
Yeah.
So yeah, the core temperature, but then you have to have an intravascular device that's looking at core temperature, like a pulmonary artery catheter or some other device that's got temperature. But the bladder temperature is pretty closely correlated with core temperature. And all of these patients we treat with the device have a bladder catheter with temperature measurement. All of them. Good. Okay. Well, thank you very much indeed for your contribution. I hope that's been useful to you, and wish you good luck and enjoyment with the rest of the conference. Thank you, Rinaldo.